Although pregnancy is considered a normal process with minimal risk, there is always the potential for the development of risks and complications. The best practice is to anticipate and attempt to reduce risks or prevent the occurrence of complications. A pregnant woman has the potential from changing from being a normal low-risk pregnancy to being very high risk very quickly. So in this voiceover, we're going to review some of those antepartum complications. These are the topics that will be covered in this voiceover. They are all discussed in detail in your textbooks. We will also be discussing them during the pregnancy and birth lectures. This is another graphical depiction and cheat sheet. Hypertensive disorders of pregnancy are covered in another voiceover. Cervical insufficiency, as defined by your text, is the inability of the cervix to retain a pregnancy in the absence of the signs and symptoms of clinical contractions or labor or both in the second trimester. Cervical insufficiency, or you may have heard it as an incompetent cervix, results in painless cervical dilation. If it's caught early enough, or in a patient that's had a history of previous cervical insufficiency, a cerclage can be placed, basically like a purse string suture that goes around the cervix and to help reinforce it. Cerclage would need to be removed at 36 weeks, or if infection develops, or if labor begins before 36 weeks. The nurse's role with cervical insufficiency is the pre-op and post-op education that the client will need prior to having the operative procedure done. And then also she'll need to be taught the signs and symptoms of labor and signs and symptoms of infection. And they'll need a lot of emotional support. There's always the threat of loss of the pregnancy. Hyperemesis gravidarum, or just hyperemesis, is vomiting during pregnancy so severe that it leads to dehydration, electrolyte imbalances, and weight loss. And this weight loss is greater than 5%. This goes beyond the feeling queasy every morning, the nausea and vomiting that sometimes accompanies pregnancy. This is severe, and these people are miserable. It is physically and emotionally debilitating. Most often, they'll need to be brought to the hospital to be rehydrated. So you'll be looking at lab work, you'll be monitoring I&O, weighing these clients daily, providing emotional support. There are medications that are used in the management of hyperemesis, specifically vitamin B6 and doxylamine that goes by the brand name Diclegis, is approved specifically for hyperemesis, but other medications like Zofran may be used as well. Pregnant women can also develop gestational diabetes, impaired glucose tolerance that results in hyperglycemia, usually due to some insulin resistance that develops because of the placental hormones. All women are tested for gestational diabetes around the 24th week gestation with a standard 1-hour glucose tolerance test where they drink a 50-gram oral glucose drink, and then an hour later they check the blood. As long as it's less than 140, the patient does not have gestational diabetes. If the 1-hour test comes back greater than 140, the client will then take the 3-hour glucose tolerance test where they're fasting the night before. Then that morning they're going to take a 100-gram oral glucose drink, and their blood levels are going to be drawn at 1, 2, and 3 hours. And if 2 of the 3 results are higher than the guidelines, they are diagnosed with gestational diabetes. A lot of gestational diabetes during pregnancy can be managed with diet. However, if that diet alone is not working, insulin will be prescribed. Oral hypoglycemics are usually avoided during pregnancy. The client could be followed by the OB, a maternal fetal medicine specialist, or an endocrinologist for the gestational diabetes, depending on the providers available. The risk to the fetus with the gestational diabetes is that they're going to be large at birth, which could also result in birth trauma and may result in neonatal hypoglycemia, low blood sugars after birth. Because of these risks to the fetus, the moms will also get non-stress tests and biophysical profiles during the later stages of pregnancy, during the third trimester. They'll also get a couple extra ultrasounds to track the size of the fetus and may be delivered a little bit earlier than 39 weeks if the fetus is getting too large. Women who are carrying more than one fetus, of course, are at higher risk for complications. Twins or higher orders are associated with higher rates of almost every potential complication of pregnancy there is. Not only is the mother at risk, the fetuses are as well, due to the fact that they're sharing space and placental circulation. Some twin pregnancies are at higher risk than others, especially if the fetuses are sharing both an amniotic sac and a placenta. This is called monochorionic monoamniotic twins. Mono twins, as they're called, can develop into conjoined twins early in gestation, or later on you could end up with them entangling in each other's cords and potentially cutting off circulation to one or both of them. Another common complication for women in pregnancy is preterm labor and birth. Now, preterm labor is regular contractions of the uterus that results in cervical change that occurs before 37 weeks. Preterm birth occurs between 20 weeks and 36 weeks and 6 days. The top 3 risk factors for preterm labor or preterm birth are a prior preterm birth, multiple gestations like the twins we just talked about, and uterine or cervical abnormalities. Signs and symptoms include the uterine contractions and feeling pelvic pressure, amongst others. Medical treatment for preterm labor will include tocolytic medications which suppress uterine contractions, neonatal neuroprophylaxis with IV magnesium sulfate to reduce the risk of cerebral palsy in fetuses born before 32 weeks gestation, and corticosteroid therapy, antenatal steroids to help with fetal lung maturity. Nursing actions. Immediate care typically occurs on labor and delivery until either delivery occurs or the client is deemed stable enough to go to the Antepartum unit and hopefully home. Providing emotional support is always important for these clients because they are scared and anxious. So in addition to the medical care that these clients need, they'll also need a lot of support and education. As the nurse, you'll be responsible for monitoring the fetal heart rate and maternal contractions. Continuous external fetal monitoring is used in labor and delivery. Then if the client is transferred to Antepartum, non-stress tests will be performed, usually every 8 hours, and whenever the client reports contractions have returned. So another antepartum complication that can occur with preterm labor or by itself is premature rupture of membranes. This is when the bag of water breaks before the onset of labor. If this rupture occurs before 37 weeks, it's called preterm premature rupture of membranes. Once ruptured, most women will go into labor in about a week. This is called the latency period, although I have seen sometimes up to a month of a latency period. There is no optimal approach to this, but expectant management is the norm. You're carefully observing the client in the hospital until 34 weeks, at which time they will be delivered, because at that time the risk of prolonging the pregnancy with the ruptured membranes increases beyond the risks to the fetus being born a little bit early. The treatment is similar to what you see with preterm labor, except that you're also adding in, you're watching a lot closer for signs and symptoms of infection, which would include foul smelling vaginal leakage. As we're discussing antenatal complications, you're hearing a lot about fetal surveillance, how to monitor the baby. And there's a couple different ways that this can be done. One of the most simple ways is fetal movement counting, daily kick counts. The mom takes a break and specifically focuses on the baby moving inside, notes the time, and there should be at least 10 kicks within a 2-hour window. Most women will get them much more rapidly than that, but a normal kick count is the mother perceiving 10 fetal movements within that 2 hours. And once she's done that, that completes the daily kick count. They could do this every day at home. If they go into a provider's office or are hospitalized and have a history of complications, women will often get a non-stress test, or an NST. And this uses the external fetal monitor and monitors not only the baby's heart rate patterns, but also monitors if there's any contractions going on. And when they're monitoring with the fetal heart rate transducer, what you want to see is accelerations or increases in the fetal heart rate, at least up 15 beats from its baseline for at least 15 seconds. And you want to see this happen twice in a 20-minute period. If it doesn't happen in the first 20 minutes, you can add another 20 minutes. So a positive non-stress test will have those 2 accelerations occurring within that 20-minute time frame. Vibroacoustic stimulation is a screening tool that could be used where the provider can give an auditory stimulus to the fetus while the NST is going on, if the NST is not reactive. Provide an audio stimulus like a buzzer next to the abdomen and see if the fetal heart rate reacts. A biophysical profile is an ultrasound assessment for fetal status used in conjunction with the NST. So it's a total of 10 points, 2 for a reactive NST, and then 2 or 0 for each of the other components. You're using the ultrasound to observe for fetal breathing, fetal tone, fetal movement, and amniotic fluid index. A reassuring biophysical profile is an 8 out of 10. The amniotic fluid index measures the amount of amniotic fluid with an ultrasound to assess fetal well-being and placental function. You can have too little amniotic fluid, called oligohydramnios, or you can have too much amniotic fluid, called polyhydramnios or hydramnios. Hydramnios, polyhydramnios can cause preterm contractions. On rare occasions, a contraction stress test is done. This is a screening tool to assess the ability of the fetus to maintain a normal fetal heart rate in response to uterine contractions. And this is done by giving the client a dose of oxytocin, which is a medication that will cause contractions. What you are looking for with a contraction stress test is that the fetal heart rate stays okay, that there's no decelerations in response to these contractions brought on by the oxytocin. Now we're going to take a look at hemorrhagic conditions of pregnancy. There are conditions that happen early in pregnancy, like spontaneous abortion, ectopic pregnancies, and gestational trophoblastic disease. And there's also hemorrhagic conditions of late pregnancy, like Placenta Previa and Abruptio placentae. The term abortion is defined as the loss of pregnancy before a fetus is viable. Despite what the name tends to conjure up, the term abortion includes both spontaneous loss of pregnancy, typically referred to as a miscarriage, and induced or elective terminations of pregnancy. For the purpose of this lecture, we're only going to focus on spontaneous abortions. And these are defined as non-viable intrauterine pregnancies with either an empty gestational sac or gestational sac containing an embryo or fetus without fetal heart rate activity within the first 12 weeks of gestation. Chromosomal abnormalities, such as Turner syndrome, account for roughly 50 to 60% of spontaneous abortions in the first trimester. Other causes include maternal infections or endocrine disorders such as insulin-dependent diabetes or hypothyroidism. There are several types of spontaneous abortions. A threatened abortion is uterine bleeding and cramping occurring, but the products of conception haven't been expelled. Up to 25% of all women will experience light bleeding, typically referred to as spotting, during early pregnancy, and about half of those pregnancies will not survive. Vaginal bleeding can be brief or last for weeks. Other symptoms may include uterine cramping, persistent backache, or pelvic pressure. Pain and pressure are more likely to be associated with ultimately losing the pregnancy. Any bleeding in early pregnancy should be considered a threatened abortion, and the woman should be advised to notify their healthcare provider. As the nurse, you should obtain a thorough history, including gestational age or last menstrual period, the onset, duration, and amount of bleeding, and any other discomforts such as cramping, backache, abdominal pain, or pelvic pressure. Any sign of fever or uterine tenderness is suggestive of infection. You can anticipate that an ultrasound will be ordered to determine the presence of a viable intrauterine pregnancy. Serial beta HCG levels may also be assessed for proper rising. An inevitable abortion occurs when abortion is unable to be stopped, such as when the membranes rupture and or the cervix dilates. Bleeding may be present and is often heavy. Generally, no further intervention is necessary as the uterine contents, including fetal tissue and the products of conception, are naturally expelled. If tissue remains or bleeding becomes excessive, the woman may require a D&C, or dilation and curettage. This fully cleans the uterine walls and of any remaining products of conception. An incomplete abortion occurs when some, but not all, of the products of conception are expelled. Bleeding and cramping continue until the uterus is completely evacuated. Initial focus is on ensuring cardiovascular stability. A type and screen should be drawn to find out the woman's blood type, an IV line placed for fluid replacement, and for possible drug administration. These women will likely require some sort of intervention, such as medication or a D&C or D&E, a dilation and evacuation, if this occurs at a later stage of the pregnancy and the fetus is larger. A complete abortion occurs when all the products of conception are expelled from the uterus, cramping and bleeding subside, and the cervix closes. No additional intervention is necessary unless excessive bleeding or infection develop. A missed abortion occurs when pregnancy becomes non-viable, but no uterine bleeding, cramping, or passage of tissue has occurred. This is different from stillbirth because it occurs during the first half of pregnancy. Generally, when the fetus dies, early pregnancy symptoms resolve. The uterus stops growing and may even decrease in size. Generally, the pregnancy ends spontaneously after the fetus dies. If this does not occur on its own, a D&C or medication management may be employed. If the missed abortion remains undiagnosed, infection and disseminated intravascular coagulation, or DIC, could occur. Recurrent abortion refers to a woman who has had 3 or more consecutive spontaneous abortions. The most common primary cause is believed to be genetic or chromosomal abnormalities or anomalies of the woman's reproductive tract, such as bicornuate uterus or incompetent cervix. There can be other reasons, such as systemic diseases like lupus, reproductive infections, and some sexually transmitted infections. Nursing considerations for abortion will depend on the management, whether it be expectant, medical, or surgical. You're definitely going to be monitoring vital signs and bleeding, checking labs, maintaining IV access. If the mom is Rh negative, she will need RhoGAM administered. And you'll be watching for complications such as hemorrhage and hypovolemic shock. You'll also be providing emotional support for the mother who will be grieving the loss of the pregnancy. Ectopic pregnancy refers to implantation of the fertilized ovum in an area outside of the uterine cavity. More than 95% are in the fallopian tubes, usually the ampulla, which you can see in the diagram is in the middle portion of the tubes. Typically, these patients present with amenorrhea, followed by abdominal pain and vaginal bleeding. The incidence is higher in non-white women and older women, and risk factors include previous ectopic pregnancy, pelvic inflammatory disease, infertility, pelvic or abdominal surgery, endometriosis, prior tubal surgery, or a history of sexually transmitted infections. Up to 50% of women diagnosed with an ectopic, however, will not have any risk factors. Early signs and symptoms of an ectopic pregnancy include the missed menses, accompanied with abdominal and pelvic pain, spotting, or light bleeding. The urine pregnancy test will be positive. Subtle signs and symptoms can depend on the site of implantation. If the implantation occurs in the proximal end of the fallopian tube, rupture of the tube may occur in 2 to 3 weeks of the missed period. Symptoms include sudden severe pain in one of the lower quadrants of the abdomen. Pain is typically accompanied by intra-abdominal hemorrhage. Irritation of the diaphragm, manifested by shoulder or neck pain that's worse on inspiration, occurs in about 50% of women. Signs of hypovolemic shock may develop with no or minimal external bleeding. Weakness, dizziness, or fainting can occur secondary to the blood loss. Vitals can become unstable, indicating hypovolemia if there is a significant hemorrhage. Ectopic pregnancy is diagnosed with the use of transvaginal ultrasound and serial beta-HCG tests. Typically, the HCG is present, but at lower levels than expected. Management of an ectopic pregnancy depends on whether or not the fallopian tube ruptures or is intact. Medical management can generally preserve the tube and thereby improve future fertility. It is most successful if the tube is intact, pregnancy is early, and the size of the pregnancy is less than 3.5 centimeters and the fetus is not living. The client will be given methotrexate, generally in a 2-dosed or fixed multi-dose therapy. Methotrexate is a folic acid antagonist that interferes with cell reproduction and inhibits cell division of the embryo. Serial measurements of the beta HCG levels are used to evaluate success of drug therapy. Surgical management involves either linear resection in an attempt to save the fallopian tube or in removal of the tube completely. A ruptured ectopic usually results in removal of the tube completely. As the nurse, just as with spontaneous abortions, you need to prevent or identify hypovolemic shock. Next, you want to worry about pain control, especially in the women who experience a ruptured ectopic. They can have acute abdominal pain, and I can attest to that. Since they are losing a pregnancy, the woman and her family may need emotional support and could be going through anger, grief, guilt, self-blame. They may be anxious due to the fear of being able to have a future pregnancy, especially if they had to have one of the fallopian tubes removed. As far as medication instruction, if the ectopic was treated with methotrexate, the nurse must educate the woman on the signs and symptoms to expect, especially nausea and vomiting. The woman needs to be instructed to refrain from drinking alcohol or ingesting vitamins containing folic acid, which would decrease the medication's effectiveness. For those women treated with methotrexate, they need to have a follow-up because medical treatment is not always effective and surgery may be necessary. Finally, patients need instruction on signs and symptoms of when they should call the healthcare provider, including bothersome drug side effects or worsening symptoms that suggest rupture, such as pelvic, shoulder, or neck pain, dizziness or faintness, and increased vaginal bleeding. If the mother is Rh negative, she will also need RhoGAM as a result of the bleeding. Gestational trophoblastic diseases are a spectrum of diseases that include benign hydatiform mole and gestational tumors such as invasive moles and choriocarcinoma. They are relatively rare, occurring in 1 to 2 of every 1,000 pregnancies in the United States, with a higher incidence among the very young and older women. Hydatiform mole, also known as a molar pregnancy, occurs when the trophoblasts develop abnormally. To review, trophoblasts are the cells that attach the fertilized ovum to the uterine wall, basically acting like the anchor. As a result of this abnormal growth, the placenta, but not the fetus, develops. The hydatiform mole is characterized by proliferation and edema of the chorionic villi, which, if not diagnosed and treated in a timely manner, will allow grape-like vesicles to grow large enough to fill the uterus to the size of an advanced pregnancy. Malignant change and proliferation of trophoblastic tissue is a life-threatening complication. The affected woman can experience acute respiratory distress if the vesicles of the mole enter the woman's circulation and embolize to her lungs. Persistent gestational trophoblastic disease may undergo malignant or cancerous changes, resulting in choriocarcinoma, with possible spread to the vagina, lung, liver, kidney, and brain. Generally, most molar pregnancies are diagnosed with an early ultrasound that reveals the vesicles and no fetal gestational sac or cardiac activity. The woman's beta HCG is very high and she generally feels awful. She has excessive nausea and vomiting, likely due to these elevated levels. Her uterus is more enlarged than you would expect for her gestational age, and she likely has vaginal bleeding. Additionally, she's at high risk for developing early preeclampsia, early being before 24 weeks. Once diagnosed, the woman will need baseline imaging and labs. She will need an IV because a vacuum aspiration will be needed to extract the mole. They would dilate the cervix and then evacuate out the molar tissue. Once the molar tissue is removed, the woman will be given IV oxytocin to contract the uterus. Follow-up is crucial to assess for choriocarcinoma, and this is through serial beta-HCG levels every 1 to 2 weeks until 3 negative levels are attained. Pregnancy must be avoided during this follow-up period because it would then obscure any evidence of choriocarcinoma. If beta-HCG levels do not fall or they're rising after initially falling, malignancy would be suspected, and chemotherapy is the treatment of choice and has a high cure rate. Placenta previa is an implantation of the placenta in the lower uterus. This is when the placenta is completely or partially covering the cervical os or the opening through which the fetus would deliver. And this occurs in about 1 in every 200 pregnancies. Risk factors include endometrial scarring through a previous placenta previa or a cesarean birth, impeded vascularization, maybe due to hypertension or advanced maternal age, and increased placental mass due to a large placenta or multiple gestations. There has been some change in the nomenclature regarding previas, whereas they used to be classified as marginal, partial, or total, depending on how much of the os they covered. Now, however, they're usually referred to as previa if they cover any portion of the cervical os, and low-lying placenta if they are nearby. It's not uncommon for a woman to be diagnosed with a previa early in pregnancy and have it resolved by the time they deliver, because as the placenta grows, it also gets drawn upward as the myometrium beneath it develops with the pregnancy. The classic sign of placenta previa is the sudden onset of painless uterine bleeding in the latter half of pregnancy. Most cases of placenta previa are diagnosed by ultrasound prior to having any issue with bleeding. The bleeding can be scant or profuse and can resolve spontaneously only to recur again later. Some women with previa won't have any bleeding at all until they are in labor and making cervical change. For women with a known placenta previa, digital exam, also referred to as vaginal exams, should be avoided because they can cause trauma to the placenta, causing severe maternal and fetal bleeding. Management will depend on the amount of hemorrhage, fetal well-being, gestational age. Ideally, you would want to prolong the pregnancy as long as you could, allowing for the fetus to mature. Any placenta previa will be delivered by cesarean section because the risk is too great of hemorrhage to allow for vaginal delivery. The woman with placenta previa can be managed with inpatient care or home care depending on the criteria. Now, to go home, they have to be clinically stable with no active bleeding. They have to be able to stay on bed rest, so no other children running around that they'd have to take care of. Their home isn't too far from the hospital, and emergency transport is available 24/7. With inpatient care, you will always maintain IV access for the client. You'll also keep the type and cross match current in case any bleeding episodes occur. You'll have the chart ready for an emergency cesarean section should that happen. Nursing assessments will include assessing for the presence and amount of bleeding, evaluating for any signs and symptoms of preterm labor, periodically performing the non-stress tests, and if you notice any changes in any of these, they are to be reported to the provider immediately. Abruptio placentae, or more commonly referred to as placental abruption or just abruption, is the separation of a normally implanted placenta prior to the birth of the fetus. If this occurs, there's bleeding and formation of a hematoma on the maternal side of the placenta. As the clot expands, further separation occurs. Therefore, the severity of the abruption is dependent on the amount of bleeding and the size of the hematoma. And this is dangerous for both the mother and the fetus. The major danger for the mother is obviously hemorrhage and potential for subsequent hypovolemic shock and clotting abnormalities like DIC. The fetus is at risk for lack of oxygen, blood loss, preterm birth, and stillbirth. The absolute cause is still unknown, but risk factors for abruptions include hypertension, smoking, multigravidas status, abdominal trauma from a car accident or domestic violence, history of a previous abruption, and something that I've seen most frequently in practice is maternal use of cocaine. There are 5 classic signs and symptoms of abruption that include vaginal bleeding, which may or may not reflect the true amount of blood loss because part of the abruption can be concealed. Then you have abdominal and low back pain that's usually described as aching or dull. You get uterine irritability on the monitor with many frequent low-intensity contractions. There's also a high uterine resting tone recorded when using an IUPC. And there's uterine tenderness that may be localized to the site of the abruption. Women with abruptions come in and they're in pain. They may or may not be bleeding, depending on whether they have a concealed hemorrhage or not. Their uterus feels more firm than the average woman, and instead of a regular contraction pattern, you'll see frequent little contractions on the monitor or by palpation. If the woman's water breaks, it'll likely be a port wine color rather than normal clear fluid because it'll have some blood in it. Depending on the type and severity of the separation, the woman's abdominal pain can be severe and sudden, or intermittent and difficult to distinguish from labor and contractions. Eventually, the abdomen will become increasingly more firm and board-like and very tender. Any woman experiencing signs of abruption needs to be evaluated immediately with a focus on fetal well-being and maternal hemodynamic stability. Expectant or conservative management in an inpatient setting is an option if the abruption is mild and the fetus is less than 34 weeks gestation and there's no signs of distress with minimal bleeding. Similar to management for Previa, these women will be on a form of bed rest, may receive tocolytic medications to help decrease uterine activity. A blood test called the Kleinhauer-Betke, which detects fetal red blood cells in maternal blood, can be used to determine if fetal bleeding is worsening. For the Rh-negative mother, Rogan will likely be ordered to help prevent maternal Rh sensitization. Unfortunately, not all women are going to be candidates for expectant management and will require immediate delivery. These are the women with fetuses who show signs of fetal compromise, such as a low baseline heart rate or fetal bradycardia. Or they might be having repetitive late decelerations and or have minimal or absent variability. As the nurse, it is important that you're always able to recognize those warning signs of abruption and promptly get the woman the attention she needs. As always, you should be providing her with emotional support while assessing maternal and fetal status so that problems can be detected early before either of their condition deteriorates. Life-threatening complications of bleeding in pregnancy include hypovolemic shock and disseminated intravascular coagulation, DIC, both of which have been mentioned previously. So hypovolemic shock is acute peripheral circulatory failure resulting from loss of circulating blood volume. Symptoms of hypovolemic shock include a rapid pulse, lightheadedness, syncope, and a falling blood pressure. DIC, or disseminated intravascular coagulation, is a complex condition where the body is breaking down blood clots faster than it can form clots. So the blood clotting factors are depleted and hemorrhage results and can quickly lead to maternal death. Priority in treating DIC is the delivery of the fetus and placenta when it's an OB cause. Both of these conditions would need blood replacement products and possibly cryoprecipitated fresh frozen plasma and platelets to be administered to maintain circulating blood volume. If you have any questions after listening to this voiceover, please feel free to email me.